Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about head and neck cancers with Dr. Saral Mehra. Dr. Mehra is an associate professor of surgery and otolaryngology at the Yale School of Medicine. Here's Dr. Weiner.
Just as we start, how is it that someone becomes interested in the field of ear, nose, and throat? And then more specifically, how is it that you got interested in cancers that arise in this region that is the head and neck?
Right. So when I was in medical school in New York City, I didn't know what ENT was, barely. I thought maybe they'd take some tonsils out, put some ear tubes in, but I had a mandatory rotation. And what I loved about ENT right off the bat were I realized that they did surgeries that I did not imagine an ENT surgeon in my idea of one would do. But more importantly, the culture of ENT surgeons and otolaryngologists just fit with me. They worked hard, did some really delicate, fine work, and had a good time doing it. And I thought, this is the type of culture and specialty I want to be in.
That's great, and it's an area where the anatomy is really complicated. I mean, there are all these structures in our nose, mouth, throat that just are all very close to one another and yet serve very different functions.
Totally agree. And that's really what I enjoyed about it too. Working in the nose, you're right next to the eye and the brain. Working in the neck, you're near important cranial nerves that move the tongue, that help with speech and breathing. It's just really intricate, fine anatomy and requires a lot of attention to detail, which again, I thought really fit well with my personality.
And when you made the decision to apply to residency programs in ENT, ear, nose, and throat, did you know at that time that you were interested in cancer?
Definitely not. In fact, it was almost on my short list of subspecialties within ENT I would probably not do. There were long, complicated surgeries, difficult patients, challenging social issues, in addition to a disease that it can be devastating to many patients. But during my journey in residency, I saw head and neck cancer done as a team and done right. And once I saw the team approach to head and neck cancer care, that's when I realized this was definitely the specialty for me. It's like every patient, it's like a new sports game. I played a lot of sports growing up, and I was a key member of a lot of different teams. I was a range guy, and that's what head and neck cancer is. It's a team sport.
Yeah. So people are very familiar with breast cancer and colon cancer and even pancreatic cancer and, tumors like glioblastomas, because some very famous people have had them, are in the news. People know a little bit less about head and neck cancers. I think that's partially in the past because maybe there were fewer famous people who had them. And also because it's an area where there are many different types of cancers. Can you just talk a little bit about all the different cancers that exist?
Yeah, it's strange in a number of ways. As you relate it to other cancers, it's definitely not one of the big four, the big, however you want to classify them. Head and neck cancers make up about 4% of all cancers in the United States. There's about 66,000 new cases diagnosed each year. And you think about it, that's actually a pretty small number when you compare it to breast and the colon, the big ones that you mentioned. So it's relatively rare, and those are the numbers. And not only that, it's sort of, as you pointed out, it's a weird term, head and neck cancers. Really, it comprises cancers in the mouth, the throat, the nose, the salivary glands, and then in the neck, like thyroid or skin cancer. So it's this whole milieu of different types of cancers. We'll have carcinomas, we'll have sarcomas, we'll have even diagnosed lymphomas in the head and neck. So it is a huge variety of cancers that show up in this part of the body.
Yeah. And of the 60,000+ people who develop head and neck cancers, we've made progress, but how many people are still dying from these cancers?
Yeah, unfortunately, it depends, or fortunately, when you catch the cancer. For advanced stage head and neck cancers, meaning cancers that have spread beyond just the primary site, survival rates are still, unfortunately, around 50% at 5 years. You can look at it two ways. We can cure for long term half of the patients with stage 3 and stage 4 cancer, which is great, but it's also we can't cure about half of them. Now, early stage cancers, ones that are caught early, we can cure 80-90% plus of those patients. So it really comes down.
And those are cancers that haven't spread to lymph nodes. They're localized in a given organ, like in the tonsil or on the tongue.
Exactly right.
Yeah. And talk a little bit about the risk factors for head and neck cancers, because there is quite a spectrum there, and not everyone is at equal risk. There are some people who are dramatically higher risk.
Absolutely. The big 3 risk factors that we talk about in head and neck cancer are ones that your listeners might be well aware of: tobacco and alcohol. That's all the cancers, not all, but many cancers. And those are and
they synergize, correct?
Exactly right. Yeah. Totally. Tobacco is a biggest risk factor. Alcohol is a risk factor, but as you point out, they synergize. When you combine the two, the risk factor doesn't just double. It goes up significantly more than just double, probably 10 times. So those are the 2 big ones that we talk about. But the third big one that we don't talk about as much is the HPV virus.
And how long have we appreciated that? That's, when I was a medical student quite a number of years ago, we didn't really know about HPV and head and neck cancers.
I agree. In our field, the HPV-associated head and neck cancers is almost a new disease. We're talking really identifying it and thinking about it maybe only in the last 20 to 30 years. And for a new disease, that is a very short amount of time in the grand scheme of things. And this is the one head and neck cancer that is on the rise. All of our smoking, drinking related cancers, the mouth cancers, are decreasing, but HPV-associated head and neck cancers are really on the rise. We're talking probably more than a 200% increase in the last 20 years.
And is that because there's more HPV?
That's a great question. I wish I had a great answer for you of exactly why it's on the rise. It may be related to certain behaviors, or it may be just related to something in the environment that's impacting the ability to clear the HPV. The HPV virus has been here forever. Most people are exposed to it at some point in their life. The vast majority of people may be exposed to it, but clear it. It's this small percentage of maybe 2 to 5% of people who don't clear the HPV virus. And within that, there's a very small percentage of people who go on and develop a cancer in the throat from the HPV virus.
And this is, in theory, a set of cancers that could be prevented with vaccination.
Absolutely. We have the HPV vaccine, 9-valent. It's been around. It's been used for girls and women for years, but now
we think of it as prevention for cervical cancer predominantly, but it also prevents these head and neck cancers.
Absolutely. And in fact, head and neck cancers have now, as of about 2 years ago, surpassed cervical cancer as the most common HPV-associated cancer in this country. And we think that's probably due to screening for cervical cancer and probably related in some ways to the vaccine as well.
Wow. And these HPV cancers or HPV-associated cancers, do they typically arise in any particular part of the head and neck anatomy?
Definitely. Almost all of them, I say almost all, not all, but almost all of them are what we call back of throat cancer to the layman and laywoman, but it's basically the tonsils and the base of the tongue. Sometimes a soft palate and the back of the throat, but back of throat cancer is how you need to look at it. It's not mouth cancers per se, it's back of throat cancers.
And so if you see someone who, for example, doesn't have a significant smoking and drinking history, they're 50 years old and they have a cancer that is in the back of the throat, how likely is it that that's an HPV-associated cancer?
The short answer is very likely. Back of throat cancers now make up about 70% of all tonsil and base of tongue cancers, and that's on the rise.
And my understanding is the treatment differs a little bit too for these cancers.
We're still flushing that out exactly, but yes, the short answer is they do differ. And the reason is because the prognosis of these cancers is so much better than the non-HPV associated cancers in the exact same area. And so what we're working on now throughout the country is on the de-intensification of treatment. If we have a cancer with a 80-90% cure rate, do we need to operate on them plus give them radiation plus give them chemotherapy? And the answer to that is no. And that's what we're trying to figure out. How can we give less treatment without compromising cure rates?
And we'll talk more about this in the second half of our interview. But of course, oftentimes people are afraid of backing off on treatment. But here, the consequences of treatment are often significant enough and severe enough that the whole reason to do this is of course, to give people an equally long life and a better quality of life.
Absolutely. And this comes back to one of my reasons for going into ENT. It's a lot of this is about quality of life, and treatment for back of throat cancers can impact a lot of aspects of quality of life, most importantly swallowing, but also speech, breathing, appearance, a lot of consequences to treatment.
Yeah, no, years ago, one would see people who had been treated for head and neck cancers, and oftentimes they really couldn't speak. Of course, difficulty with swallowing is still something that people have. But the treatment for this particular type of cancer at times, is maybe not worse than the cancer, but it's pretty bad.
Yeah, at times, definitely patients are probably saying that in the middle, towards the end of radiation, if they're getting chemo. You're absolutely right. They're definitely saying that.
But and we'll talk more about that when we talk about sort of the multidisciplinary nature of the work. So I think that at this point, maybe we should take a little break, and we'll be back. We'll pick up with our guest, Dr. Saral Mehra, Associate Professor of Surgery at Yale School of Medicine and Chief of Head and Neck Surgery. And we'll be talking more about this, I think, very interesting topic of head and neck cancers and all the progress that's been made.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their hematology program offers comprehensive diagnosis and treatment of blood cancers, including lymphoma, leukemia, and myeloma. SmiloCancerHospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths, but when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Eric Weiner again, here with Yale Cancer Answers. And I'm speaking with my guest, Dr. Saral Mehra, who is an expert in the treatment of head and neck cancers, and specifically in the surgical aspects of that treatment. But as a surgeon, you have to know a lot more than just the surgery, because this is a type of cancer where you are dependent upon your colleagues in other disciplines. And maybe we can start off talking about that. Who else do you interact with? When a patient comes to see you and says, Dr. Mehra, can you take care of me? Your first answer is probably, well, I can take care of you, but I need the rest of my team.
Absolutely. And this comes back to what we were talking about earlier. The reason I got into head and neck cancer is it really is a team sport. I think the team, I like to break it down into a few different groups. Basically, you have your doctors, which are one part of your team, and that's a surgical oncologist, which is what I do, but you absolutely need a medical oncologist and a radiation oncologist. Now, medical oncologists are responsible for talking with patients about the disease, the process, and they administer chemotherapy and immunotherapy when it's given and help manage a lot of the medical aspects of care. They also get extremely involved when the cancer may spread beyond the head and neck and into other parts of the body. That's when surgeons and radiation oncologists are not the answer. And our colleagues in medical oncology, that's when they really step up. And then radiation oncologists, we work hand in hand with radiation doctors to identify and personalize the treatment for patients. Like I was saying before, we want to minimize the amount of treatment we give these patients, specifically HPV-associated cancers. And that's where all three of us have to talk about the optimal treatment for the patient in front of us.
And sometimes, particularly with surgery and radiation oncology, there's a trade-off in terms of more surgery, less radiation, more radiation, less surgery. Is that
absolutely
right?
Yeah. We're shifting paradigms in this, and new information's coming out all the time. But there's a recent trial that showed that if we can remove all the cancer for a oral pharynx or tonsillar base of tongue cancer, we can actually lower the dose of radiation by more than 10%, almost 20%, and get the exact same cancer outcomes with a better quality of life. So these are the boundaries we're pushing in the field.
And 10 or 20% may not sound like that much to people listening, but the side effects increase not in a linear fashion as you increase the dose of radiation. So that, by eliminating 20% of the dose, you may eliminate 50% or 80% of the side effects.
That's what we're trying to do. Any major cancer center in the country who sees a lot of this is exactly doing that.
So you have the doctors, and probably worth mentioning that in addition to the surgical oncologists and radiation oncologists and medical oncologists, supporting all of us are the pathologists and the radiologists who we can't really live without. But then you have all the other people. And who else do you rely on? Because patients may come to a center because they have a doctor's name, but in the end, a lot of the care they receive is as a result of all the efforts that non-doctors put into the care of patients.
Definitely. I think this cancer, maybe more than others, I'm a little biased, requires a lot of therapists. We're talking speech, language, and swallow therapists. We're talking lymphedema physical therapists. We're talking about social workers and mental therapists. Some we've not talked about often, but head and neck cancers, patients who've recovered from that actually have some of the highest rates of depression following treatment. And we need psychiatrists, psychologists in the survivorship aspect of this. So really a lot of key, we call them ancillary, but really they're absolutely critical to the quality of life and rehabilitation of patients.
And then there are the nurses, of course, who are, front and center in that group.
Absolutely. We're dealing with tracheotomy tubes sometimes, feeding tubes. And when there's a problem, who do I call? The nurses to help manage them, counsel patients, teach patients. You got it.
And it's oftentimes a hard course of treatment to go through, getting chemotherapy and maybe radiation and surgery in varying orders. And oftentimes you have to take special steps to make sure that people are going to get through this. So you have to worry about how people are going to nourish themselves, and how they're going to remain hydrated if they're having trouble swallowing. So these are the things you consider as well, I assume.
Absolutely. And I think not only are they getting through a lot of different types of treatment, it's in a relatively short amount of time. Ideally, in an ideal world, if we're going to operate and give radiation or chemo, we like to get that radiation chemo started within about 6 weeks of recovering from what's often a major surgery. And that's different than other cancers where you have a little bit more time to start the chemo or the immuno or the systemic therapy or the radiation. And so a big part of that is getting them through it, having them not give up, making sure they're taking enough nutrition, and optimizing their swallowing function in the end. A lot of things to think about during treatment.
So how do you talk to patients about doing less? There are a lot of people who will come in and will say, "Doctor, I want everything that I can get to make sure that this cancer is never going to show up again. And you may have a clinical trial, or you may actually just know, based on trials that have been done, that sometimes a little less is every bit as good, or if not every bit as good, very close and maybe worth the trade-off." So what are those conversations like? And can you tell when you see somebody if they're going to be comfortable doing a little bit less?
Totally. When I see a new patient with head and neck cancer, I kind of talk to them about the journey of cancer. And during that time, you kind of get to know them and their personality. And I tell them the journey for head and neck cancer is threefold. One, get all the information. That's getting the scans, getting the consultations done with the multidisciplinary team, getting everything ready to go. I tell them this is probably the most frustrating part of your journey because you know you have cancer. You think we're not doing anything, but you're actually in the most important part of your journey. And this, I tell them, is really important. I could operate on you tomorrow, but what if I do an unnecessary operation, impacts your swallowing, and you could have just gone straight to radiation in a few weeks and had the exact same outcome with less side effects? Once I start talking to them about that, I think they realize it's worth the trade-off to do the right workup, to see all the multidisciplinary team, and get less treatment if it's the right thing for you. Interestingly, I think I have less of that problem than maybe other cancers because people read, I guess, on Google, the internet, whatever, about the side effects of head and neck cancer treatment. And most of them are happy to take less treatment as long as they have the confidence it's not going to impact their cure rates.
Sure. No, it's, these are often hard discussions. And, it's interesting. When someone's first diagnosed, they're often willing to, or say they will go through anything to absolutely minimize the chance of a recurrence of the cancer. But what sometimes is less apparent is that dealing with side effects that extend for a year, 2 years, 5 years, or in some cases a lifetime can be pretty devastating. And I suspect that's partially related to the high rate of depression in many patients after treatment for head and neck cancers. Is just dealing with the chronic problems that just never seem to go away, which is what you're trying to avoid.
I think you're right. If you have a patient with a cancer of the voice box sitting in front of you and you tell them, I could remove your voice box, but I could try and save your voice box, not operate, give you other treatment with the exact same cure rate, it's not a tough decision for a lot of them.
Yeah. So Tell us a little bit about the research that you've been involved in over these past 5 to 10 years.
Great. My research is really focused on the process of cancer care delivery. It's a field of research called health services research. It doesn't get all the fame and glory of fancy new drugs and medications, but in my hypothesis and theory and why I'm so interested in it is I think as a health services researcher, we can make just as big an impact on outcomes and care of patients throughout the world as the next fancy blue pill. And that's what I do.
If you can't deliver that blue pill to everybody, and if people have trouble taking it or people have trouble accessing it, it's not going to do anyone much good. So we have to figure these things out.
Exactly.
So
that's why I think
tell us more about what you do.
Exactly. So I think we need to work hand in hand with the researchers who are making the fancy blue pills, because as you pointed out, how do you get it to people? How do you decrease variation in cancer care delivery across the country? Somebody in one part of the country should have the ability to get the same quality of care with the latest and greatest information that somebody in another part of the country has access to. And that's basically my research. We look at national trends, we look at regional trends, and we look at barriers to accessing that care and delivering that care. And we've found some really interesting and drawn some interesting conclusions about this. And most importantly, I think, is just raised awareness of the variability and differences in care.
And finally, in our last minute, and maybe this is sort of backwards, and I should have asked you this to begin with, but can you just leave our listeners with a few comments about the kinds of symptoms that they may have that should lead them to seek attention for a possible head and neck cancer?
Absolutely. And I think it's a great way to end, because we are all about awareness in head and neck cancers. We don't have fancy screening guidelines like lung cancer and breast cancer and colon cancer and prostate cancer. We are all about awareness. So symptoms that patients need to be aware of when thinking about head and neck cancers would be a sore in the mouth that doesn't heal after a few weeks, maybe 4 to 6 weeks. Everyone gets a sore once in a while, a canker sore, but they heal. Something doesn't heal, seek attention. If you have throat pain, one-sided, not getting better after 4 weeks, 6 weeks, seek attention immediately. Referred pain to the ear can sometimes be associated with deeper cancers in the throat that you can't see. Voice changes, raspiness of voice, difficulty swallowing. And then for HPV cancers, one of the most common presentations is actually a neck mass. Before you even find anything in your throat or have a symptom in your throat, a lump in the neck. If you're above 35 and have a lump in your neck develop, go get that checked out immediately and ask about the possibility of an HPV-associated cancer.
Dr. Saral Mehra is an associate professor of surgery and otolaryngology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.